Welcome everybody. It's great to see a great big group of people joining us today. We're thrilled to welcome you here for this collaborative practice and roles for healthcare providers session today with the Peace Project. I just want to make a note that this presentation is being recorded in video format by Alberta Health Services. The recording may be used and disclosed by AHS for educational purposes and may be further broadcast by AHS for other presentations, publications, or promotions. That may include conversion to digital format, storing, and publication on AHS webcasting technology. So again, just want to welcome you and introduce ourselves today. I'd like to introduce my co-chairs of the PEAS Roles and Implementation Working Group. Vanessa Steinke is a Senior Project Manager with Alberta Health Services, and she's the Lead Project Manager and Superwoman for the PEAS Project. Tricia Miller is a Manager of SLP, Audiology, and Children's Allied Health in the South Zone for Alberta Health Services, And my name is Melanie Matisse-Dewar. I'm a Manager at Alberta Children's Hospital overseeing Allied Health, rehab professionals, and professions and programs, So the objectives for today, or focus for today, is what tools are available to you, your teams, your families, with respect to roles in pediatric eating, feeding, and swallowing services. And so our objectives today are threefold. First of all, we'd like to share the collaborative practice toolkit created by our working group. We'd like to review the information and evidence around role clarity, which guided our development of role resources, including tools to assist teams to work through role clarity discussions. And we'd like to give a broad overview of collaborative goal setting and share some resources around this topic. Our group is driven by the evidence-based fact that interprofessional collaborative teams are key to eating, feeding, swallowing safety and success. And before we dig in too much, I'll just make a quick pitch for the other training opportunities that have occurred or are coming up in the summer and fall. As you can see, we've had 3 training sessions over the past few days, and we've got another set of training sessions planned for October or into the fall, October and November. Each of these sessions is being recorded for future viewing, and they are stored on the PEAS website, which you'll get to explore just in a few minutes with Vanessa. And also just note that we are actively working out details for what our innovation learning collaboratives will look like in light of the COVID response. We've got some planning to do, so stay tuned for information about that. I'm going to pass it over to Vanessa.
Great, thanks so much, Melanie. So I'm just going to give you a really quick overview of the PEAS project. So the Pediatric Eating and Swallowing, or PEAS project, is a provincial quality improvement initiative with the purpose of developing a clinical pathway to standardize and improve care of children with a pediatric feeding disorder, as defined by Gaudet et al. For this phase of the project, our target population is for children in the ambulatory care setting. So we've focused many of our resources on outpatient and community care, but they can be very easily applied or adapted for other care settings like acute care. At the outset of this project, we hosted 2 World Cafes, one in Northern Alberta and the other in Southern, just to understand what was currently working and what was not working in the care of children with eating, feeding, and swallowing difficulties. The results were very homogeneous, so regardless of where people lived in the province, whether they were north or south, urban or rural, they came out to show that in the most significant barrier to care was access to service and access to information, and a very close second was a lack of role clarity and communication. So these are just some examples from the World Cafe of the issues concerning families and care providers around role clarity and communication. You can see here there were concerns about understanding who provides what service, that services occur in silos, that goal setting was lacking, as well as multidisciplinary care. So this is why the PEAS project has a multidisciplinary provincial working group involving leaders, healthcare providers, and families to develop tools and support improved role clarity and interprofessional collaboration that is child and family centered. We're looking forward to sharing these new tools with you today that can all be found on our new website. So that website address is peas.ahs.ca, and today we'll be navigating you through the collaborative practice and role resources for healthcare providers, but we encourage you to watch our other presentations that give you a high-level overview of the website and also the clinical practice guide, and just to peruse the website yourself. Something else we're excited about is that the website is very mobile responsive and can easily be shared with families. So we're delighted to have a few special guest speakers with us joining us today, including Julie Evans and Carmen Lazarick from Alberta Health Services Health Professions Strategy and Practice, and they'll be introducing themselves shortly. But first, we'd just like to introduce you to Mona Danda. And if you had a chance to attend the CPG session, Mona shared some of her family's story as it relates to the clinical aspects of care. And in this presentation, she shares her journey as it relates to collaborative care, roles, and goal setting. In addition to being a mom of a child with an EFS disorder, Mona is also an IT project manager for AHS, whom we've had the privilege of working with to launch the new PEAS website. So Mona wasn't able to actually attend today, but she kindly had us record her presentation for you to be able to listen to. So I'm just going to play that right now.
Thanks, Vanessa. So this is a picture of my daughter, Isha. She did and still has challenges with feeding herself and receiving the appropriate nutrition she needs. And so then to give you some background on history on her, she was not premature. She was born, she was in distress, and so we had an emergency C-section. She had congenital heart failure, she had respiratory issues. There was that unknown diagnosis of trisomy 21. And she was taken by Stork to the Royal Alexandra NICU, and we spent 4 weeks there where she was on a feeding tube, and she was also diagnosed with permanent hearing loss when we were there. And the next slide, please. So during the first year of Isha's life, we felt very supported. Although we didn't have specific assistance with feeding, we were seeing an SLP at the Edmonton Down Syndrome Society. We saw an SLP at the Connect Society. We received physiotherapy from home care, and then we had, all of our specialists and so on. We also had referrals to the Glen Rose. At the time, I declined that because I thought we were double dipping services. I saw that we already had 2 SLPs, one for hearing loss and one for Down syndrome, but they both focused on her speech. And so we didn't really have any assistance in feeding and swallowing. And I guess that was, I didn't know that that was the role of an SLP or an OT at that time. I also didn't know how complex the basic skill of feeding yourself would be. And because Isha had a cognitive disability, I didn't realize that that was something that could be taught as well. And so, 8 years ago, I wish PEAS existed because I would look at this circle diagram that you have under the care coordination section in PEAS. And I would have likely understood the type of providers that I might have had involved in our life. I would have definitely sought some intervention at that time. I hope for new families that they can look at PEAS and learn about coordination of care and realize that regardless of where their child is in their journey, they'll have some support and who they can turn to. I eventually did learn all of this, but not until some years later. And I do believe in early intervention, so I regret some of the choices that we made. Now, the next slide is her toddler years. Isha progressed. She was able to eat soft foods, and I started getting her to swallow foods. I would dose everything in yogurt and cut it up into small chunks. But that was even, not sustainable. And then also on top of that, you can see that she was really challenged in terms of getting food into her mouth on her own. So we did our best, but if I had PEAS at that time, I think things would have changed for us, not just in terms of teaching her how to feed, but in terms of ensuring I had the right emotional support. I did seek counseling at that time, and there's a self-care section in PEAS that provides a lot of options for families that are experiencing overwhelm. At the time, our SLP was costing us $180 out of pocket, and we're currently paying $135 for 45 minutes. And 60% of that comes out of pocket because of, you know, the type of healthcare I have here at EHS. And so PEAS also explores different funding options that are available to families. And so I actually decided to seek intervention because at this time we completely isolated ourselves. We stopped taking her to birthday parties, and I had a terrible attitude. I didn't want to see other children thriving because I was jealous, and that was actually hurting her. Keeping her from those gatherings was you know, not beneficial for anyone. And so now when I look back, like, we've experienced collaborative care. There are a lot of things she still can't do in terms of feeding and other functions, but I'm not bothered like I was before. And I think the key difference is that I know that I've experienced collaborative care. I know that with the right assistance from the right type of team, that there are things I can do to help her succeed. And I think it was that feeling of not knowing what to do that really depressed me at that time. And so move forward, 3.5 years later, we received specialized services. And so we had a great team. We had an OT, behavioral consultant, SLP and SLPA, and we had a communication book that we shared amongst each other with quarterly reviews. It involved everyone on the team. Our clinicians kind of worked together, so they would share their notes with the other disciplines, so we didn't have to communicate our goals over and over again to them. We would do family goal setting, so that would keep us on track and we were all on the same page. And actually, I would say that feeding was the largest group effort because it involved everyone on the team. You know, we had to use the right language, work on her posture, work on jaw alignment, and, you know, we had our behavioral consultant that would help her to get excited for food and not frustrated because all she wanted to do was just drink yogurt and ice cream. Previously, we had 2 different SLPs, and that was also stressful from 2 different organizations because they would give us advice that would clash, and it was hard to decide what to do. The other great thing I thought about collaborative care was that they looked at our needs as a family and not just Isha as an individual. So everyone got involved, including my older child and my younger child, and so it was really amazing that we all had a role to play to help Isha, and they taught us how to provide care and give us some tools in our back pocket to give us confidence and help us to assist her. And so now, the next slide, please. We transitioned to school, and so now Isha's in a community school. She's repeating grade 1, and she has to decide whether she goes to recess or she eats food because she just doesn't have time to do both. And so that kind of results in some behavioral concerns, and she's fatigued by the end of the day. And I realized that it's complicated in terms of the school board has their own OT and PT and the teacher, and so we're not sure, you know, who's involved in helping her to feed because they all are very busy and you're working on helping an entire class. But we do know that throughout our journey, we've had a constantly evolving care team, and we've experienced different type of care. And I can strongly say that we've been the most successful as a family when we were part of a multidisciplinary team. I am so excited that teams are focusing on collaboration and that PEAS makes all the resources available to families. I'm really hoping that the information on PEAS is going to provide families to be more proactive rather than reactive, as I feel that we were the last 8 years. If I would have known, or families know that and understand right from the beginning that they're not alone on this journey, and they in fact could have an entire team of medical professionals at their side, it will reduce the feelings of overwhelm and ultimately provide better care for their children. Thank you so much.
Hi, this is Julie Evans, Practice Director for Provincial Speech Language Pathology, and I have the privilege of thanking Mona for sharing her journey and her learning along the way, and just the joy she brought by letting us get to know Isha a little bit through her story. It's so powerful for us to hear about the differences our approaches make in the lives of children and families beyond our clinical influence. And so we really appreciate the opportunity to learn from her and to know that she talks about being on the journey not alone, but with a collaborative team around her. And so I really like to think about the balance of that, or the opposite of that, that we have the support of the families we work with in this journey that we're on as professionals. And so certainly Mona and Isha provide inspiration for our work. I'm going to pass it to Carmen Lazarick, Practice Director for Provincial Occupational Therapy, and then I'll be back in a minute.
Thanks, Julie. Thank you, everyone. So next slide, we're going to be talking for a moment about the child and family. The child and family are at the center of what we do. In fact, putting patients first really is an AHS priority. Child and Family First is an approach to care that focuses on the needs of the child and family, with healthcare providers working together to wrap around the child and family based on what their needs are. Regardless of one's role on the team, we all have a role to play in supporting the child and family. The strengths and needs of the child and family are the foundation for how we then individualize our approach to service delivery. This client-centered approach requires that we ask the child and family to inform us, to tell us what their needs are, to inform our practice. We will talk later in this presentation about collaborative goal setting. The client-stated goals are what guides intervention. Everything we do connects back to what the child and family need from us within any given episode of care. This is what drives collaborative practice, what matters most to the child and family. Let's start with that. After all, they come first. Back over to you, Julie.
Okay, a little bit about professional practice. Really, we provide excellent child and family-centered care through excellent professional practice. And sometimes we think our individual clinical competencies and skills provide the foundation for professional practice. But if you look at the C on the right-hand side of your screen there, you'll see that individual competence is one of really 10 factors that go into and are important for professional practice. So indeed, those competencies are essential. However, the literature is clear, and our interviews with clinicians and leaders have reinforced that quality person-centered care really depends on the support of a strong system, as well as team competencies and the competencies of the individual clinician, and their caring, their commitment to professional regulation, their collaborative skills, etc. How our system enables clinicians and teams to work effectively is key to professional competence. So how teams communicate and work together is crucial to the safety and all aspects of quality in the care of our patients and these little infants and kiddos. We just heard about the difference communication and collaboration made in the life of Isha and her family. Our individual competencies, including our collaborative competencies, are integrated with team competency and system supports to put professional practice in action. In preparing the resources that you're going to learn about today, clinicians work together to better understand the unique and overlapping contributions among and across disciplines. They were brave in challenging their own assumptions and those of others, challenging how their teams worked together and thinking about those relationships differently. Regulatory colleges, AHS, interprofessional regulatory affairs, COACT, physicians, and multiple disciplines came together to create a really robust set of tools that we believe will help you to put professional practice in action to address what matters to children and families.
Thanks so much, Julie and Carmen, for being here today and for speaking to the importance of collaborative practice, and to Mona and Isha for their story, which just illustrates the value in this work and the value in putting some energy into our teams and building them up to be stronger. So thanks to everyone. We'll dig in a little bit around collaborative practice here for a few minutes. We were so fortunate to have been able to partner with COACT to harness the power of the work completed through this Alberta Health Services initiative over the past few years. The COACT Collaborative Care Design provides a framework and an approach to implementing and sustaining collaborative care across the care continuum. The guiding principles and pillars underpinning all COACT collaborative care elements include patients first, so patient and family-centered care, high-performing teams, building our teams up for success, and quality culture, better value, better experience for everyone involved, professionals and families and patients. Having the advantage of adopting and adapting COAC's carefully created materials has been a huge boon to the PEAS project. It really allows for continuity and consistency across care contexts and areas of practice. This graphic we wanted to show you as a first is it really illustrates the goals of the PEAS project with respect to building strong collaborative care teams and enhancing coordination of care and communication within the eating, feeding, and swallowing area of practice. The feedback from the PEAS World Cafes indicated a disjointed or siloed current state, with teams separated by their discipline, their geographical area, or even the clinical program within the same site. Our goal is to provide teams with information and tools to help build care teams that are centered around the child and family and operating under a shared goal of best patient care with fluid communication between all members of the team. We really want to promote interprofessional care, bringing together the unique perspectives of varied disciplines, regardless of whether people work in co-located teams or are geographically spread out. As we mentioned, we had the benefit of working together with COAC to develop our collaborative care elements for PEAS, and they've become part of the PEAS Rules Handbook. The 4 resource bundles included in our handbook are listed on this slide, and they're designed to support the operationalization of principles of collaborative care. They are interdependent and applicable across the care continuum. And instead of digging into each element individually during this presentation, I'm going to show you where they're located on the PEAS website, and I'll encourage you to take the time to review each of the elements yourselves. On the website, if you go to the For Providers section, you'll see collaborative practice listed along the left side, and you simply click on collaborative practice and then read more under the collaborative care primers and resources section. The 4 elements of team charter, collaborative care team, assignment of care, and collaborative care leadership are accessible here as printable PDF documents. We'd like to share a bit more specifically about developing a team charter, as we found this to be a very valuable and edifying process for any team to undertake. Across Alberta Health Services, teams have found that developing a team charter facilitates ownership of collaborative working relationships in the care environment. It enables the team to function in an empowered manner and provides a link between the team's goals and Alberta Health Services' overarching mission, vision, values, and goals. A team charter is a collaboratively developed description of the team members' responsibilities, accountabilities, and working relationships in the care environment. It defines the purpose of the team's values, operating rules, and accountabilities. It provides the scope and approach to collaboration, outlines expectations, behaviors, and commitments. It also provides an agreed upon process to resolve interprofessional conflict if it arises. Creation of a team charter really needs to be initiated and driven by leads, and every team member's contribution is equally important and valuable to the process. It's a living document that should be revisited on a regular basis, and when new team members are oriented to the practice setting. We'll be looking at facilitating an opportunity to work with team charters at our Innovation Learning Collaboratives. And the PEAS website will give you access to a team charter primer, as you saw on the previous slide or info sheet, and a development guide, templates, examples of charters developed by existing pediatric eating and swallowing teams, such as the one that you see here. So this one is an example of a charter that was developed by one of the EFS teams working here at Alberta Children's Hospital in my area. Working through this process with a number of our teams has been gratifying, it's been productive and challenging, and it's provided the opportunity for a shared reference point during all role-related discussions amongst team members. On the website, additional collaborative practice primers and resources can be found just below the team charter and include collaborative care team, assignment of care, and collaborative care leadership elements. Each of the materials are brief, just 2 pages, and they include practical concepts, suggestions, and steps to implement and enhance collaborative practice. We'd encourage you to review them with an eye to how these key principles of collaborative practice may be put into place in your context to support practice, process, and quality care. I'm going to hand it over to Tricia now.
Okay, thanks, Melanie. So going back to the original purpose of the provincial project, the lack of health provider role clarity was one of the top concerns presented by families that we serve when we held the meetings fall of 2018 in Calgary and Edmonton. The CADITH evidence review in 2017 also provided clear direction that a team approach is required to best support safe feeding and swallowing assessment, care coordination, since dysphagia is considered a complex health issue. We will cover your role in this next section in the various slides coming up. The PEAS Roles and Implementation Working Group initially tackled review of role resource supports for healthcare providers. Once the role resources were completed for healthcare providers, the resources were adapted for families to utilize in order to support the family journey related to their child's eating, feeding, and swallowing care. For healthcare providers, you'll find the AHS developed PEAS roles descriptors and tasks within full scope on the new website under collaborative practice. These tools are intended to be used together as a package where you find specifics related to role descriptors such as scope of disciplines and the overview of roles. In addition, the tasks for each discipline are a comprehensive list for an individual working at full scope of practice. Keep in mind that not every individual representing a particular discipline will be ready to work at full scope, but we wanted to ensure that each health discipline college or regulatory body confirmed each discipline's maximum scope. And because PEAS is an advanced area of practice, we acknowledge that individual healthcare providers may seek additional training and mentoring to work at full scope. So when we go forward, you can see that together with families, clinicians, AHS Health Profession Strategy and Practice, AHS COACT, professional colleges, and the PEAS Project has developed the PEAS roles descriptors and tasks within full scope so that healthcare providers can provide EFS clinicians with an adaptable tool to use as a way of highlighting, communicating, clarifying overlaps and gaps within a team. Also promote that interprofessional care and bring together those unique perspectives, regardless of where people, if a person works in a geographically spread out area or if they're co-located. Also focus the care team members on their collective team competence to address that child and family centered goal for eating, feeding, swallowing, and provide a tool to identify and cover gaps in services. As part of the roles, descriptors, and tasks within full scope, we have developed a diagram that addresses roles, shown here on the left, outlining the multiple and different care providers. And you'll see on there the dietitian, OT, SLP, psychologist, the physician, lactation consultant, nurse practitioner, and others. Also outlines the different trainings and skills, and of course, that central role of the family in interdisciplinary care. The roles and implementation working group also discussed how the whole visual image would be blurred so that it just depicts that the role of the team waxes and wanes and becomes blurry at times. So the role of different disciplines is captured in a blurred color document. When we look at the triangle displayed, we have clarified that individual scope of practice is determined by ministerial regulation, professional regulations, employer policy, and individual competence. Melanie and I just wanted to share some experiences that we've had at our sites. So to start with, at Medicine Hat Regional Hospital, it became important for staff and managers to get better clarity on roles based on past confusion with eating, feeding, swallowing work. So we looked at the sustainability of the service when providers move from unit to unit or were taking on different positions. Every time we review a team's functioning on a various unit or site, we often look at roles. This then allows for respect of the various work of the different disciplines, and we acknowledge that the work can be complicated and touchy, but it depends on each team's composition. We all needed to review our scope of practice and then look at overlaps to determine what we were comfortable doing as a team, and we definitely learned a lot together. There were aspects of service we discovered to better serve a family, like using the education department. Wayfinding was improved, and we all had a better understanding of where to transition a family and a child, such as acute care, service, community, outpatient, public health, allied health. We wanted to discover who was the most appropriate person to do a task on our team for the safety of the infant or child. Each team documented their decisions on a chart so that we were transparent as disciplines, and it provided some clarity. It built our understanding of when to involve another discipline, pending the roles decision of the team. And after reaching consensus on discipline functions at Medicine Hat Regional, the team members and managers expressed greater satisfaction with their delivery of service to infants, children, and families.
Thanks, Tricia. At Alberta Children's Hospital, an opportunity was identified to ensure that a full interdisciplinary feeding team is consistently available to infants and families in our neonatal intensive care unit, and to enhance coordination of care around eating, feeding, and swallowing. We worked to ensure that there was FTE available from each of the disciplines identified as key players in feeding, and those disciplines include nursing, neonatology, dietetics, lactation consultancy, occupational therapy, speech-language pathology, and social work, not to mention a focus on highlighting the parents as expert team members. Weekly feeding rounds were initiated about 6 or 7 months ago, which has allowed real-life experience to guide role clarity and collaboration between team members. Feeding plans are being made and are agreed upon by the family and interdisciplinary team after discussion and input. Feedback from the team is that service has become much better coordinated, care is shared and more efficient, the level of service availability has improved significantly, so then timeliness has as well. And even in some cases, length of stay for these families is shorter, which is fantastic. From the nurse practitioner who spearheaded this work and continues to provide leadership to this team, she sent us a quote. She said, "This work has brought the team to a point where we are cohesive. It's amazing and so important for our babes and families."
Super, thanks, Melanie. And in addition to the roles, descriptors, and tasks within full scope, we have worked with AHS Interprofessional Regulatory Affairs to create a frequently asked questions document that can be found under the additional resources page under collaborative practice. In Alberta, all healthcare professionals are required to follow provincial healthcare laws, the legislation and regulation, professional college standards, employer governance, and self-regulation when they provide healthcare services to clients and patients. These requirements are primarily in place to ensure Albertans receive quality, safe healthcare services. Healthcare providers from different disciplines may have similarities in their education and training. Despite the parallels, the role of each profession remains distinct as defined by the professional practice statements, regulatory college standards of practice, and the competencies that are unique to each discipline. So with the 5 areas shown, the restricted activities is documented in the Government Organizational Act, Schedule 7.1, talks to a master list of healthcare activities that are restricted. These activities are restricted because they're considered to be risky and require specific education, training, and competence. And the term diagnose is not a restricted activity. Some professions have it within their scope of practice, in their practice statements, college standards, and competency profile to diagnose, and others do not. And the dictionary defines diagnosis as that ability to recognize and name the exact character of a disease or a problem by examination. Then the Health Professions Act is a framework document that provides common provisions that apply to all regulatory colleges and schedules that apply to that professional college. All regulated healthcare professionals have profession-specific regulations that provide governance. These regulations provide direction for what restricted activities the profession is authorized to perform and under what circumstances they can be performed. In terms of collaborative competence and that interprofessional collaborative team, that collaborative care environment is where different regulated professionals care for the same patient in the team environment. Then the regulated member works under their own legislative, regulatory, and college standards and remains individually accountable for the care they provide. And finally, in terms of the AHS role in how professions practice, AHS is accountable to uphold Canadian and provincial legislation, regulation, and accreditation standards, also to develop process, resource, and tools to support regulated professionals to practice safely and provide quality care. AHS strategies, values, and competency statements help to describe that expectation for staff working at AHS. AHS has the authority to decide on the role of the regulated professional in their position, but they may not insist that a professional perform authorized restricted activities that are outside their professional scope. And that's captured in the Government Organizational Act. Okay, so just looking at the screen, this is the additional resources page. Just to take a quick look, there are a number of resources here, videos, documents, some great educational tools that you can look at and also share amongst your team. We also have resources for family members who are an important and that imperative member of the care team. They have an integral role as indicated in the literature, in COACT principles, and in health change methodology as endorsed by AHS, and very eloquently described by Mona earlier in the presentation. There's also information about self-care and involving people in their community, such as the schools, friends, and other community members, as well as information about finding a support network, including links to peer supports for families whose children have an EFS disorder. Under the family section, we also have information for families about their care team and the various roles that each provider may have. This circle diagram is similar to the one we just looked at for healthcare providers, but again, as Mona mentioned in her recording, it's specific to families. Finally, in the care coordination section, there's an expandable question area for families. And when we expand, who do I talk to? This kind of shows you all of the information that can be found under each section. Thank you.
Okay, back to me, Carmen again here, and we're going to talk for a minute about collaborative goal setting. There has been much provincial work over the last couple of years related to collaborative goal setting, and these successes are really because of your work locally in zones and within your program areas, and as participants in provincial work like the PEAS project. So what is collaborative goal setting? Really what we see with collaborative goal setting is that it's a clinician and team-driven sort of intentional engagement of clients and families in a shared decision-making process that results in functional client-centered goals. The client is the expert on, obviously, on their values, their preferences, and their motivations. So we really are centering ourselves around the client as the experts on what they need, and the provider being the expert on health conditions and on the rehabilitation process. Collaborative goal setting improves client outcomes. When clients and families are actively involved in making decisions about their goals, their engagement, satisfaction, and motivation improve. In practice, this really translates to improved clinical outcomes, greater client commitment in rehabilitation, improved self-management. We see things like fewer no-shows or cancellations, and fewer readmissions to rehabilitation after discharge. And really, it has been and still is an organizational priority, as I mentioned earlier. The patient-first strategy and patient-centered care are expectations in Alberta Health Services. Collaborative goal setting is really an explicit way to ensure that we are asking children and families what matters to you, and collaborating with them in order to deliver our services. So I think you'll agree that this sounds reasonable and good to do. It is evidence-based, but the next question is, how do we do this? What teams already apply collaborative goal setting in their practice, and how can we leverage these leading practices to better support other programs and teams to develop this skill set? Many teams do set goals as part of their process, but may not be doing so in a comprehensive way that is truly collaborative and patient-centered. Applying collaborative goal setting in practice is something relatively new for some providers. We have not yet achieved full consistency across the province, like within AHS. So this is one way, this presentation and a lot of the resources that have been developed for the PEAS project is one way that we can think about goals and some of the processes that we can really start to apply in our practice today. So goals should be recognizable to the child and family. They should look at those goals that are written down and they should be able to say, yes, that is definitely what is important to me right now. They should feel ownership, that they own those goals. While there may be tasks related to the goals, so for example, as an OT, the task or the sub-goal might be related to something specific to trunk control in order to use a spoon for eating yogurt. But really, from the child and family's perspective, the goal might be that they really want to and they value eating breakfast together as a family, for example. So goals are not pre-configured. We don't know what the child's goals are based on the health condition, nor the presenting symptoms and functional issues. We don't know what the goals are until we engage in a shared decision-making process to establish what matters most right now. I really like to think about collaborative goal setting from these 4 principles. So we have sort of that idea of why collaborative goal setting is important, and now we're talking about how this is done. And how do we know that it's evidence-based? So that's where 4 principles can really be helpful to remember. Collaborative goal setting involves shared decision-making. The goals are client-centered and client-stated. The goals drive intervention. And 4th, the goals are documented. It is through a shared decision-making process that we then engage the child and family in establishing their goals, and that the goals that we land on are indeed client-centered. They can drive intervention, and they can be clearly documented. And my final slide will focus on the clinical documentation of collaborative goals. So while Connect Care is not the focus of today's presentation, it is important to just note for everyone that we have been working in the background and building multidisciplinary tools in Connect Care to support collaborative goal setting in practice and to allow for documentation of goals and treatment plans. And we still have some work to do in this area. Currently in Connect Care, providers have access to an inpatient collaborative goals and treatment plan flow sheet where they can document the client-stated goals and the tasks associated with working toward each goal. And in the ambulatory environment, providers can use the treatment planning activity for easy documentation of goals and tasks. In both cases, there is the ability to document on the progression of tasks. Until all programs and services have transitioned to Connect Care, there are other tools that can support practice in the interim and in current documentation systems. So a great example of this that has been adapted for use across pediatric eating and swallowing services and programs is the goal wheel. The center of the goal wheel is the client-centered goal statement, and the shared decision-making process is used to identify the actions or tasks that will enable progress towards that goal. So we heard from Mona earlier, and I wanted to try to pull what she spoke about in terms of her experience into an example completed or partially completed goal wheel. Mona really talked to us about the importance of that coordinated group effort approach to care, and that everyone on the team needed to know what the goals were. We shouldn't expect the patient and family to be repeating their goals in every conversation they have. So it's really important to have a place where they're documented and where everyone on the team knows what we're all working towards. So here I've taken a little bit of liberty in order to give this example. So in the center, the overall goal statement from the child and family might be something like participation in mealtime, including birthday parties. And then the actions and tasks that can be included in working toward that goal might be things like increased motivation towards eating and social participation in meals, self-management strategies for family participation in reading and other communication, postural control and adaptive strategies for eating, and improving wiggle jaw and applying adaptive strategies in the sense of mealtime. So those are some examples, and just to give you a sense of what that might look like completed. It could be more information than that, more comprehensive, or as simple as what you just saw. So just going back to the PEAS webpage for a moment here, it really does provide further information that we encourage you to go and explore about setting goals with children and families. Strategies such as using SMART goals can be applied, and further tips on tracking progress on goals can be found here. I'd like to note that the green links at the bottom of this page take you to additional practice supports that are focused on collaborative practice and collaborative goal setting, and the Rehabilitation Model of Care site and the Connect Care Resource Library are excellent resources to support your ongoing program development and clinical practice. There are videos in there as well, so guidance documents and really things to support your change management. So definitely check out the other resources that are available. And back to Tricia.
Okay, thanks, Carmen. So you can contact us by email or by using the PEAS contact form. For example, you can feel free to suggest any additional tools or handouts that you would like to have review by PEAS leadership, and those tools that are approved would be posted on the PEAS website. Here's the form. Okay, and also, if you would consider subscribing to upcoming news and events through the website, you can do that here by clicking on that button and subscribing, of course, to the community of practice. As chairs of the, in terms of questions and comments, just wanted to open it up to everyone and see if there's anything coming forward. I'm just going to click on the question and answer page. Are there any supports for pill swallowing? Just wondering if any, Vanessa.
Hi. Yeah. Hi, Luann. Did you email us this morning, by the way? Someone else asked us that same question, and we're just going to be getting back to you soon. There is some information in our clinical practice guide around pill swallowing for children, and it's just links to other resources that Alberta Health Services has made available. So I'm not sure if that's sufficient information, but we were just going to email back if that was you. And yes, we will definitely send out a copy of the PowerPoint slides. I'll be sending them right after this presentation. Thank you. Luann, sorry, I hope that answered your question. And I'll even just take down your information. We can send you the same info if you weren't the same person that asked that same question today. Thank you.
I think there was one comment in the chat box that at ACH, the child life therapists also contribute to that work. So yeah, thank you for that comment. Also looking at the question and answer. Last session, you mentioned certificates. Yes. Vanessa, did you want to comment on the certificates? Or the...
Yeah, absolutely. Just as a team, we discussed it earlier this week, and I think what we'll do is just let people request a certificate of attendance, and we'll send those out to you as individuals if that's something you would like. And I'll just note that when we send out our email, if you wanted to, I will make sure that gets to you. Thanks, Crystal. Yeah, that's a great idea, Cynthia. We'll post the presentation, the PowerPoints as well on the PEAS website. So I'll just post that right underneath the recording of the sessions as well. So great that you guys are finding this content useful. The session last week. Yeah, so I'm just in the midst of literally getting the, whoops, let me just go pull that up. Getting the recordings online. And we have the one for overview and new tools already posted. I'll just show you where those are. So under for providers, you can click on professional development. And probably later today, I'll have the session posted from the clinical practice guide session as well. But right now you can see overview and new tools is up. We'll get CPG on, and then after probably next week, I'll get the one that we just did today online as well. And right underneath that, there's the survey for feedback, and I will also post the PowerPoint from the session too.
That sounds great, Vanessa. Thank you.
Thanks.
Great questions. Anything else coming to mind, or is that it for the moment? You could always reach out to afterward to the email or to the page that was shown earlier in the presentation, where you can submit questions or comments there as well. All right. Well, I think we could head off into the last bit of our presentation. As chairs of the PEAS Collaborative Practice Roles and Working Group, Melanie, Vanessa, and I wanted to reiterate that I think we've mentioned this in other meetings. The working group members were very integral and very much leaders in putting together this information. And this PEAS Steering Committee has provided us with great leadership and guidance in our journey. We're thankful for their steadfast clarity in the purpose of this work, and also to the PEAS leadership team. And above all, we want to make sure to thank family advisors and family members who've supported the purpose and vision of this work. They're like our North Star.
Thank you, Trish. This is Julie. I just encourage everyone to please stay on the line for a couple of more minutes. I want to thank all of our working group members and those of you who supported this work in so many ways. The depth and quality of resources you've created is absolutely astounding. And then before we close today, we'd just like to take a moment to remember Wendy Johansson, who was part of the PEAS Roles and Implementation Working Group. Wendy was a highly skilled and compassionate clinician who made a real difference in the lives of so many infants, children, and families. Across the healthcare system, we relied on her. I relied on her for clinical expertise and for her passionate leadership in the area of pediatric eating and swallowing. Wendy was a force within PEAS, involved with the CPG, the clinical practice guideline, and really touching on all aspects of service improvement. She had such a clear vision of our ability to create cohesive, coordinated, truly excellent services for infants, children, and their families. Wendy Johansson passed away on July 21st, 2020. Her legacy lives on. Through our work to improve services for children and families, we will continue to honor her. Let's take a moment now to remember Wendy. On behalf of the PEAS leadership, I would like to express our most sincere condolences to all of Wendy's colleagues, friends, and loved ones. Our hearts go out to all of you. Thank you again for being part of this session this afternoon. We really appreciate your participation. Take care and have a lovely summer, the rest of it. Bye for now.